Is the sound working now? Okay, excellent. Sorry about that. This has been a very embarrassing fail, but I will start again. Can you properly see the slides? Are you just getting midterm 2 review? Okay, so hold on. I'm just going to try and make it so that you guys can see the slides, and then I'll go over some of the questions that you had again. Just give me 1 second. We're going to try and do it like this. Okay, hopefully this is working. Sound is okay. Okay, well, sorry about that again. I'll do my best and start over and try and answer some of the questions. Can you see the screen? Okay. Great. So I'll do my best now and try and explain this diagram here, which was presented in the textbook. And to be honest, I think that this is maybe a little bit more complicated. That is than is necessary for this class. So there are a few things here, like delayed hypersensitivity T cells. Those were not discussed at all in the textbook. So I think maybe the focus for this would be more on knowing the general pathways and some of the main players in the immune system. So we do have three different immune pathways here. We have cell-mediated immunity and nonspecific immunity, and antibody-mediated humoral immunity. So all of these cells, the T cells, the granulocytes and monocytes, which are also known as white blood cells, and the B cells, all originate in the bone marrow. The T cells will then mature in the thymus. The B cells will mature in other structures of the body. So I'll just start by going over the nonspecific immunity. So this is when this is called nonspecific because the white blood cells will attack anything that they see is not part of the body. So any kind of foreign invader in the blood, any bacteria, any virus, they will essentially swallow those by a process called phagocytosis, which is mentioned in the textbook, but maybe just know the name. So they will engulf these invaders, they will essentially chew them up, and they will present a small piece of the foreign invader on their surface. So this piece is going to act as a signal, and it's going to activate the T cells and the B cells, which I'll talk about in a minute. So the cell-mediated immunity is going to involve the T cells. So once the white blood cells have presented this little tag, the T cells are going to pick up on this, and then they're going to differentiate into a number of other types of T cells. So one of those types is the killer T cells. So these will directly attack any infected cells. We also have the memory T cells. So these ones are going to remain in the body, and they're going to essentially serve as a memory. So the next time the same kind of foreign invader comes in, they're going to reactivate, and they're going to be able to respond a lot faster because they won't have to go through this whole process. We also have the helper T cells and the suppressor T cells, and in general, you can just think of these as the ones that are going to modulate the other ones, so affect the activity of the other ones. So the helper cells are going to secrete lipokines, and they're going to affect the activity of other T cells. Suppressor T cells are going to be the ones to tell the body to scale down the immune response after the infection has occurred, so that you're not constantly producing T cells day after day after day after you've had a cold. So we also have the antibody-mediated humoral immunity. So this pathway involves the B cells. I think that's the most important thing to know. And the B cells are going to also respond to these white blood cells here. And then they're going to differentiate into two different types of cells. They're going to differentiate into the memory B cells. So these are going to act just like the memory T cells. They're going to remain in the blood, and they're going to reactivate when they see the same pathogen again. They're also going to differentiate into plasma cells, and these ones are going to be the ones that are going to produce the antibodies that we commonly know. So I just included this little diagram here, so maybe just to get an idea about how they differentiate, really, really basic level. This is obviously not a biology course, so it's just important to know the general concepts. But we do have the B cell here, so this is the B cell lymphocyte that you might have seen mentioned in the textbook. Is going to differentiate into the memory cells on one hand, which are going to hang around long after the virus has been beat, and it's going to wait for the virus to come again so it can reactivate, and then also these ones which will be producing the antibodies. Do you have any questions about that? Is there anything that's unclear? Anything I can help a little bit more with before you continue? Okay, so I'm just going to continue with some of the other questions that we got. So one of the questions was, are obsessions linked to past experiences? So this question was referring to an example given in class where the woman had OCD and she kept leaving her car to go check behind her car to see if there was a child there because she was so afraid of hitting a child. So the question was asking if she had had a past experience with this or maybe why it occurred. And I think the answer to that generally is not necessarily, because there are a lot of different types of obsessions. Some of them can be very violent or very sexual in nature. And these are things that the person would never engage in. So people can have an obsessive thought where they're in the kitchen, they're around knives, and their obsessive thought is saying, you're going to kill your friend. Obviously, they've never done this. They've had no experience with this. They've never had a friend murdered or been stabbed. But this intrusive thought is coming in, and then they're going to perhaps engage in a compulsion, which is going to try and reduce some of the negative affect associated with that obsession. So this kind of brings us to one of the next questions that I received, which is how do compulsions lower the frequency of obsessions? And this was mentioned very briefly in the textbook. It was not discussing the mechanisms of it in any way. But in context, I think what this was trying to say is that these obsessions bring about this really negative affect, and the compulsions can help reduce that affect. So then perhaps the obsessions would occur less often. So I did also receive a question about agoraphobia, which was asking if agoraphobia is essentially defined by the fear of having a panic attack in public. And I thought that it would maybe be most helpful to take a look at the DSM-5 criteria for agoraphobia, which I found on this link here that you can check out. I think they did a really nice job of presenting the DSM-5 and the DSM-4 diagnoses and the changes between that. It's very detailed, but it might be a nice supplement if you want to read a little bit more. So agoraphobia is defined by a marked fear of anxiety about 2 or more of the following 5 situations, and you can see them here. It's not necessarily about having a panic attack anymore. If you look at the DSM-4 diagnosis, it's a little bit different. But if somebody is afraid of being in public transportation, being in open spaces, being in closed spaces, standing in line or being in a crowd, or being outside the home alone, then they would meet criteria for agoraphobia, regardless if they were afraid of this because they were going to have a panic attack. So I do also have here, this is just straight from the slides, but there've been a few questions asking about punishment and reinforcement and maybe giving some more examples of that. So I thought I'd break it down a little bit. So when you do see these names like positive reinforcement, negative punishment, there's 2 parts to them. There's the positive or negative and the reinforcement or punishment. So reinforcement is when you're trying to increase a behavior, and punishment is when you're trying to decrease the behavior. Positive, on the other hand, is when you're going to be adding something into the environment to try and get the effect, and negative is when you're going to be removing something from the environment. So I'm just going to do a few examples of that, and that might make it a little bit more clear. So positive reinforcement, so just to break it down, positive, adding something into the environment, reinforcement, because you're trying to increase the chance of a behavior happening again. This would be like giving your child a sticker to get them to do their chores. Negative reinforcement, on the other hand, would be taking something away to increase the chance of the behavior. So you have the negative part and the reinforcement part. So that would be like having a really, really loud alarm go off, be on constantly, and then only turning it off when your child starts doing their chores. So this can get a little bit confusing. It's not putting on the alarm to get them to stop, but it's turning the alarm off to get them to do something. Positive punishment is going to be adding something into the environment in the hopes of reducing a behavior. So your child is throwing a tantrum, you really want them to stop. So to get them to stop, you're going to hit them. Please don't actually do this, obviously, but this is just a really good example of positive punishment. Negative punishment, on the other hand, is going to be removing something from the environment to decrease the chance of behavior. So the child is throwing a tantrum, you really don't want them to throw a tantrum, so you're going to remove their favorite toys until they learn how to behave. So hopefully those examples maybe help clear it up a little bit. So we also do have some questions about this study here. And I just want to start by making it very clear that these are not the results of the study. These are hypothetical results that would represent how the outcomes of this study might look if hippocampal volumes were a sign or a consequence of exposure or a vulnerability or risk factor. So the larger bars are going to indicate more of an abnormality. So this is a little bit weird to get your head around because the study is actually talking about smaller hippocampal volumes. So the larger bar, the more abnormal the hippocampus. So this one here, with this first graph, this would suggest that the hippocampal volume abnormalities are a sign of PTSD. So that they would come on after the PTSD. So you can see this because it is only the individual with the PTSD who is going to have the increased abnormality in their hippocampus. On the other hand, we have this graph over here. So this one is going to be showing that hippocampal volume abnormalities are a consequence of exposure. So you can see that the two people who have been exposed to combat are going to be the two who have this increased abnormality, and those who are not exposed to combat do not. So it's very clearly, if you've been exposed to combat, the bar goes up, the abnormality goes up. This one, on the other hand, is going to be the one that's going to suggest a risk factor or vulnerability factor. So you can see this because we have the twin here who has PTSD, who has been exposed to combat, but we also have the twin over here, the sibling of this twin who was not exposed to combat. So regardless of the combat, there was something else that was causing this increased abnormality. And this would suggest that it might be a risk factor. So I think the bottom line with this study in general, it's very important to understand maybe how you would know something is a sign, a consequence, or a vulnerability factor. But the study itself that used this terminology here, this study found that combat-exposed twins with PTSD and their unexposed co-twins have smaller hippocampal volumes. So this would be like the third graph over here. These other graphs, they have nothing to do with the study, they're just hypothetical. Okay, so there's a few other brief questions that I got. So one of them was, why does performance-only social phobia include casual speaking and eating? So when you return to the textbook, if you read the paragraph, they're contrasting performance-only social phobia and social anxiety disorder. So I think this is the key distinction to take away from this, is that performance-only social phobia is specific to situations like eating or performing. So it wouldn't be so to go in contrast would be social anxiety disorder, which is a fear of interacting in most social situations. So where social anxiety disorder is a general disorder, performance-only social phobia is specific to something. So just to eating, but not to being at a party, or not to performing, or just to performing, but not to eating or not to being at a party. I also got another question. Why is Thomas Joiner's theory called the interpersonal psychological theory? So his theory was discussing what people need to actually go through with suicide. So in class, we talked about overcoming the fear of death. So people would expose themselves to painful and fearsome experiences to reduce innate fears of death. But his theory says that there are other things, and this is where the interpersonal comes from. It's a little bit out of scope about what we talked about, but this was thwarted belongingness and perceived burdensomeness. So basically the feelings that someone would feel within a group, these negative feelings of not belonging or feeling like a burden, and then also this one that we did discuss, which is overcoming the fear of death. So those are all the slides that I have for today. I did receive a few other more specific questions that I am happy to answer directly, but they were more about the wording of specific sentences in the textbook. So I will try and get around to those comments as soon as possible. If anyone else has any other questions I can answer right now, um, please go ahead, let me know. I'll do my best.